So hi, I'm David Brown from Dallas. Paul Shishil, thank you. Paul, I want to congratulate you on, in this era of meeting fatigue, some new interesting topics and what you put together, a great platform, and really looking for a new niche in some of this meeting fatigue place. So this is what is Cohort C, and as you've heard from everybody, from Dr. Holmes and Shishil and Danny, when TAVR is so easy. Disclosures, and as we start this, let me do something here real quickly for fun. Everybody in the audience that does TAVR, raise your hand. Just raise your hand high if you do TAVR. High, 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 and down. And then for the lucky part of the group for this presentation, who doesn't do TAVR? Raise your hand. Okay, so this is Paul's brilliant creation to get you CME credit for the social science part and the ethics part. So a little bit of science poured on social science that Paul decided to throw in here. So we're going to take a little magic carpet ride here and some social science. Partner 1 trial, you already know, and TAVR, SAVR equivalent, certainly better than medical management. But what happened as this evolved, even in the design, when we asked the surgeons the first time as they were designing the trial, how many people did you turn down last year who were referred for aortic stenosis? They said none. What they didn't know were all these people who were hiding out in primary care offices and cardiologist office who were sicker than anybody had seen and didn't know what to do. So as they came along, fundamentally they got put in the inoperable category and randomized to medical management. But it also created this term and this definition that we'll see evolve of Cohort C. And the fact is now we know that there's a Cohort C for SAVR as we started this, but the question you're having to answer today in the clinics when you're seeing them is who, as David and others noted here, who's really Cohort C and who should not have TAVR if it's become so easy. And you saw Danny's slide that said, hey, we're going to do this, even valve and valve, you're going home tomorrow. 80% of everybody going home certainly within the first 2 days. But this is what the surgeons seen. They rarely turned them down. Now we've got Cohort B moving into Cohort C, and we're really finding out there truly are Cohort C patients for TAVR. I love the David Letterman top 10. I couldn't find the 10th one, so we're going to have a magic carpet ride through Dr. Brown's top 9 and see if we can fly through these and see what happens. ESRD, so end-stage renal disease, what do we know? There's an increased 1-year mortality against other extreme risk patients. The great news is the surgeons thought, well, this is terrific. I don't like operating these patients. It skews my statistics. I wind up with mortalities at 30 days, 1 year. I'll just dump them over to TAVR. We found out very quickly we had the same problem. At one point, we even found out that we had a 1-year 47% mortality in the patients we did with dialysis. So we put a moratorium on them. We stopped doing it. We looked at it. We've looked at those things. We also saw that, well, we can restore them to the natural life of what happens if you have hemodialysis without severe AS, but what's the risk, and what's the risk to your program, what's the risk to public reporting, what's the risk to cost, all the things that you know and love. So we've gone through the moratorium, we've gone through every version of who's in, who's out, the things you saw about Shishil's heart team, the debates that go on, the social science of this, the ethics, and wind out, who's, better at negotiating who gets done. We're now taking a look at it in this age of TAVR so easy, who should you do? Cirrhosis, we've had the same problem. We know that if you look at it, the impact of cirrhosis, certainly on surgical outcomes, increased mortality, complications, length of stay, expense, everything was really not quite good. What's the difference? No difference in 30-day mortality if you do TAVR. However, poor long-term prognosis, essentially 7/10 are dead in 3 years, approaching 50% 1-year mortality. You can go through all the classifications, but we haven't come up with the right answer. We've said we'll do it if they put you on the transplant list. We recently did somebody, they said they put them on the transplant list. They got TAVR, but they never got well enough from their liver to really get to the point of being transplanted, so we have another 1-year mortality. Severe COPD. This is a topic near and dear to our heart because early on we ran into these patients who smoked, who were sent with COPD, some who never smoked, sent with COPD, and what they fundamentally had was severe heart failure. But it also affected their pulmonary functions. We would see FEV1s below 1. In one of our pride and joys is doing an FEV1 of 0.48 liters and finding out that that really is heart failure. It's not COPD. What we do know that, TAVR was better than medical management, but that wasn't a stretch, and TAVR certainly equals SAVR even in the COPD patients. But COPD had worse outcomes, and whenever you start scoring COPD, you can look at the BOSS scores, one-year mortality can increase as high as 40%. So again, you've got to ask the question, when's heart failure, where's COPD, and at what point are you still going to do these patients, and how long do you have to have as survival? David's TVT registry, certainly the same kind of hazard ratio, but even the one-year mortality, whenever you get into really severe COPD, may be 4 times as much. Left ventricular function, again, touched on a little bit both by Dr. Holmes and Dr. Kadali, and this gets to be complicated, but we go back to the Gary registry that was referred to and separate them generally into greater than 50, less than 30, 30 to 50. And what we know is that as your EF gets worse, your one-year mortality gets worse. When we move to David's TVT registry, unadjusted, there's still 1.5 times mortality whenever you look at worse EFs. But the interesting part is this is the part about lies, white lies, and statistics. I can send the whole panel into literature and probably prove most things, anything you want to. But the fact is, even as you start looking at low gradient, we won't get into the whole Science 451 of low gradient, low flow, normal and abnormal EFs, but fundamentally, low gradients really may not do you a great favor, not only whenever you have low EF, but especially whenever you have a normal EF. Particularly as we drop down below 30, you get into the question, when you get to 25, when you get to 20, what's recruitable, what's really going to come back, even if they don't have coronary disease, where are you going to go with this? And it's going to weigh into some of the things we're going to wrap up here with in a minute. What we found out is with LV failure and with mitral regurgitation, we weren't as concerned about mitral regurgitation until we ran into both tricuspid regurgitation and right-sided failure. As you look at this just on the right-hand side, the 61%, 16%, and you look at the hazard ratios, you can see that 5 times as much risk once you get out to severe TR. If you just look at ventricular size, you can get out into the same problem for 2.5 times the risk. If you look at the ejection fractions as well, the same kind of problem happens with 2.5 times all-cause mortality at 1 year. Now we're getting into the social sciences. Frailty, we've developed all kinds of frailty measures. We've looked at mortalities, and this is some of the things that are out of both TVT registry and out of the CoreValve trials, but certainly the ADLs, albumin, and other things besides the STS scoring have added to the risk of frailty, and we know that there is an element of frailty being in the eye of the beholder. As we add to this and look at life expectancy that we'll get to in a second, fundamentally we're looking at what is life expectancy. In the early trials, we looked at what was a 1-year survival. Were they going to be alive in more than 1 year? Was that a reason to give them a valve? Now in clinic, we look at what's the long-term result? What are we really doing? It's not just eking them past a year, but is there a life there that you're supporting? And as you move on through the categories, we get to dementia, and this is a lot like pornography. I'll know it when I see it. And this is more subjective than objective, although we have all sorts of tests we apply to it. We also get down to fundamental negotiations and disagreements about whether they have too much dementia to be done or not, and often have them go through everything from boosted nutrition to rehabilitation to return visits, repeat testing, and then a discussion about how much dementia is here and what can really be corrected if we put better flow through all their organs. Life expectancy, we're now into the idea that not only is frailty the measure, but it's the futility piece that was particularly well looked at in the CoreValve trial and fundamentally defined, looking at not only medical futility, but the physiologic and normal futility as well as you mix it in with frailty. And fundamentally, this becomes the issue of frailty, futility, and the multiple comorbidities of what are you going to do as you look at this, and are you really extending life? So in the current TAVR era, similar to cancer. You put all this together, and we're generally looking at, is there a life expectancy of at least 2 years? And is this now moves into this era? We saw the recrudescence of BAV. This is the work out of Washington Hospital Center in GW that looked at the growth of BAV after we had failed miserably in the 80s, and we found a better way to do it. We also had a better place to go with it, and as this came back, we also found out we had the same problem. If you only do BAV, you have a dismal outcome. It's not going to last very long, and so we started using bridges to TAVR and SAVR. Again, this is the work out of Ron Waxman's shop, and the aspect there that a lot of this was bridge to therapy. We used this in a partner trial early on. At first, some people thought it was even unfair play to do it in the medical arm, where we only had 10% that was done for the bridge to therapy and 10% for cardiogenic shock. But if you move to the Italians, they evolved to the point of having a third, a third, and a third of bridging and palliation to TAVR and SAVR. But if you look at this as a continuum, it really is, what are you salvaging all the way to bridging the therapy? Well, we continue to do salvage, and we continue to have a lot of debates. What is clear now, we have some high mortality rates if you measure the whole aspect when we try to do salvage BAV. And it's the issue of whether you let somebody die or whether you don't. We're back to the social science and the ethics of it. But clearly, whenever we do salvage, we know that that's worse than the outcome of just doing TAVR. The palliative therapy, we will often do as a treatment if we really decide that it is Cohort C and we're not going to do anything for you. But sometimes we clearly will use it in a place to get to the point of having a bridge to therapy. But in palliative BAV, as you look at this, now that the results, even in our institution, have, over the course of time, worse outcomes just for BAV, the question has started to arise, should we just leave a valve behind? So now you're asking the question, are you going to drop in a $30,000 valve? And the questions now become, who's going to benefit, where are the losses, who's paying, and who's going to decide? As we move to that, bridge to decision is certainly a good reason to do it, and we still apply this, but not nearly as much as we used to have to, looking at everything from low gradients, bad LVs, improving that, aortic symptoms that we're not sure which one's the cause, severe COPD versus CHF, and others. And then finally, bridge to therapy. We used to have to do that more when you were waiting for trials, but there are plenty of reasons to do it whenever somebody is not a good candidate to be done either urgently or emergently that we don't like to do for those reasons, and any prolonged times, whether it's trial enrollment or non-cardiac procedures. So is there any way to turn the volume either on or up? So you're going to have to lip sync this. Okay, so you may miss this, but you've made the big time whenever you make Gray's Anatomy. Fundamentally, he talks about the fact that he's got 13 papers to write. He's just been engaged in the Lotus trial, and I don't know what to do. Just don't be stupid and don't kill my patients. So fundamentally, Cohort C is in the eye of the beholder. Just don't kill my patients. So this next one's not going to play either, but I think you'll get the drift of it. In this age of easy TAVR, Stone Age meets Star Wars. So we've arrived at that level of development. Thank you.